To welcome you all to the beginning of our 2023-24 Frontiers in Child Health Research Seminar Series. The seminar is being held on the second and fourth Mondays from September through June, with a special seminar that was held last month, which we co-hosted with the CVRI. The series includes speakers with work focused on child health from both UCSF as well as guest speakers. Please let Roberta Keller know via email if you are interested in speaking or if you would like to suggest a speaker. Looking ahead, our next scheduled talk is on October 23rd by Dr. Marina Sirota from the Baker Computational Health Sciences Institute here at UCSF. We are still virtual and using Zoom. We will ask everyone to stay muted unless you have a question, and we will also open it up to questions at the end. I want to apologize ahead of time because I will not be able to stay for the entire conference, but Dr. Padbury will be moderating for himself and answering questions. Today, we are welcoming Dr. Jim Padbury from the Division of Neonatology. Jim's research has focused on short and long-term morbidities associated with preterm birth, with an interest in mechanistic and individualized predictors of these morbidities, and a particular focus on necrotizing enterocolitis and neurodevelopmental outcomes. He has had an interesting bicoastal career with some training as well as leadership positions here at UCSF and at UCLA, before having a full career at Brown University on the East Coast, where he served as the division director for neonatology and has now more recently rejoined our faculty here at UCSF in his pseudo-retirement. His work has been funded by the March of Dimes and the NIH. And the title of Jim's talk today is Inter-alpha inhibitor proteins, novel biomarker for neonatal sepsis and necrotizing enterocolitis. Thank you, Dr. Padbury.
Thank you so much, Yao. Let me share screen and okay. I'm delighted to speak to everyone today about a project that's been ongoing, as you'll see, and that I want to bring here in the form of a renewal of our existing support. So disclosures, this work I'm going to present has been supported by a SBIR grant, Small Business Innovation Award, to Yaopin Lim and myself at Brown University, and we're working on preparing. We've submitted our competing renewal. Yaopin is the president and chief scientific officer of Prothera Biologics. As you know, SBIRs are have to have an industry base, but they can have an academic collaboration as well. Yaopin is also a professor in the Department of Pathology and Laboratory Medicine at Brown University. So what I'm going to do today is give you some background on inter-alpha inhibitor proteins. I'm going to use the phrase IAIP, and I'll give definition to that molecular form in a few minutes. I'm going to talk about their role in adult and neonatal sepsis, show some experimental studies with IAIP, talk about the mechanism of action, and then tell you what we want to do with our new award. So inter-alpha inhibitor proteins are a complex plasma protein family. They're the products of 3 chromosomes, 5 different genes. You can see the circled in red are the circulating forms. The heavy chain, the inter-alpha inhibitor, there's a 250 kilodalton heterotrimeric protein that you can see here. Hope you can see my mouse, composed of 2 heavy chains, the light chain, and these are held together by glycosaminoglycan bonds. This is the most abundant circulating form. There's a pre-alpha inhibitor that is also in circulation, different heavy chain, and includes the light chain. And then during sepsis and post-translational processing of these proteins, the light chain, also known as bikunin, is released from the bonding to the heavy chains, and it's has a very short circulating half-life, but has some interesting biological properties. So these proteins circulate at high levels in adult plasma, very high levels, as you can see. They're rapidly consumed during immune system activation, and that's non-specific immune system activation. So sepsis, necrotizing enterocolitis, pancreatitis, viral sepsis, all have been shown to result in striking alterations in circulating IAIP levels. I already mentioned the light chain bikunin. You might recognize this as something called urinary trypsin inhibitor or ulinistatin. It's rapidly excreted in the urine. Ulinistatin, purified from the urine, has actually been approved for use in Asia and in Europe, where it's been used to treat sepsis, preeclampsia, preterm birth, and a variety of disorders associated with immune system activation. We'll be talking mostly about the 250 kilodalton interalpha inhibitor protein, which with Prothera, we've purified using good manufacturing principles from human plasma and have pharmaceutical grade material for the studies that I'll be sharing with you. So these proteins are important mediators of innate immunity. They are part of the innate immune system. There's exceptional sequence homology across the entire animal kingdom, even to very lower forms, sequence homology between both the heavy and light chains. IAIP mediate host inflammatory responses by inhibiting proteases. The antiprotease activity is restricted to the light chain bikunin, but they also block complement activation, downregulate pro-inflammatory cytokines. They bind to extracellular histones, aka danger signals or DAMPs. They stabilize neutrophils, protect endothelial cells from injury, and they reduce reactive oxygen species generation. The level is normally very high, but they're rapidly depleted during systemic immune system activation, both shutdown of liver synthesis and then rapid excretion. I'll show you studies that demonstrate that IAP treatment represents a novel approach to provide broad immunomodulatory effects in some severe disease states. So, along with Prothera, we've been involved in a large number of preclinical efficacy studies, but I'm only going to have time today to cover a few of these. So I'll cover adult sepsis and neonatal sepsis as well. Because of this audience, some of our work that's been done in fetal and neonatal hypoxic ischemic brain injury, and then comparable explanation of studies in adult ischemic stroke. So let's dive into the sepsis stuff. This work shown on this slide represents the alterations in plasma IAIP levels during severe infections in adult ICU patients. The vertical axis shows the plasma IAIP levels, and the horizontal axis shows the different patient groups comparing healthy controls and severe IAP levels in severe sepsis in patients that survived and patients that didn't. As you can see, the adult sepsis is associated with a significant reduction in the plasma circulating levels, and that reduction is greatest in those non-survivors. I'm not going to show you the data, but these are also associated with reciprocal associations with Apache score, with biochemical markers of organ injury and those sorts of things. And it was at a cancer biology symposium at Brown University when I first saw this data, and I raised my hand and I asked Dr. Lim, what about neonatal sepsis? And he said, we don't know anything about neonatal sepsis, but we would be interested in looking into that. So that began the long-standing collaboration that I've had with him on these projects. The scale of the problem in neonatal sepsis is really quite substantial. Early onset sepsis occurs, by definition, less than 3 days of age, in up to 1 per 1,000 of all live births. And given the 4 million births there are a year, that's a large number of patients. It's associated with a fairly significant overall mortality. That mortality is greatest in our earliest gestation infants, but it still represents a very significant problem. Late onset sepsis also contributes to the scope of the problem in newborns. occurs in 16% of ELBWs, and this is results from the Neonatal Research Network. It can be associated with significant disease, septic shock, multiple organ failure. A variety of mediators have been associated with neonatal sepsis, and we'll look at that a little bit later when I talk about mechanism of action. Antibiotics alone are insufficient to reverse the inflammation, hence the associated not insignificant mortality. The problem with neonatal sepsis, and actually is true in adult sepsis as well, is what is the definition? The gold standard has been blood cultures, but is that really a reliable indicator of the presence of sepsis? I think most of you know about the false negative rate of blood cultures in neonatal sepsis. It's a finite rate. That's due to the low degree and intermittent bacteremia associated with neonatal sepsis, the small inoculum size that we have available for doing blood cultures, things like intrapartum antibiotics, which can partially treat and obscure the blood culture positivity. Let me say that our studies and our opinion is don't withhold intrapartum antibiotics to avoid obfuscating the blood cultures. Intrapartum antibiotics are very effective and have been very helpful. And that 1 per 1,000 rate that I quoted from the Neonatal Research Network is in the post-chemoprophylaxis world for treating women who are colonized with group B strep. The other problem with blood cultures is delayed results. Most institutions use a 48 to 72-hour duration in order to decide about negative cultures. And this problem with blood cultures has led to a very high empiric broad-spectrum antibiotic exposure in neonates. And this is associated with significant adverse consequences, including emergence of resistant organisms, increase in the risk of necrotizing enterocolitis, alterations in the microbiome that are the subject of continuing studies. So goals to reduce, to provide good stewardship for antibiotic use in the newborn would be aided by adjuncts to the blood culture in diagnosing sepsis. We need a better biomarker that's more accurate, more sensitive, more specific, that has biological plausibility and that we can get at rapidly. And that's what I'm here to describe to you. So our foray into this after starting the collaboration with Dr. Lim was first to just do a broad survey of the plasma inter-alpha inhibitor levels in healthy infants across different gestational age groups. And as you can see, as in adults, these proteins circulate at high levels, and there's not really very much of a gestational age dependent effect on the levels. For these studies, we used a very specific laboratory-based ELISA assay based on a monoclonal antibody that's directed against the light chain. So this represents total IAIP levels, but 80 to 90% of this is the heterotrimeric 250 kilodalton form that has most of the very interesting biological features. So we looked at this in neonatal sepsis. The results are shown on this slide. On the vertical axis is IAIP levels. On the horizontal axis are the group assignments. This is infants with a negative blood culture, and this is infants shown to have a positive blood culture. On my right, you can see the ROC curve for the reliability of inter-alpha inhibitor against positive blood cultures, So you can see that the diagnostic utility of IAIP is quite good. It has an AUC of 0.9, a sensitivity of 90%, and a positive predictive value of 95%. This is to be compared with the diagnostic performance of other adjunctive tests for neonatal sepsis. So this audience understands the use of hematologic values, total white blood cell count, IT ratios, platelets, biological markers like C-reactive protein and procalcitonin, pro-inflammatory cytokines have all been studied for their sensitivity, their diagnostic performances you can see reflected across the upper part of this table. And what's most notable about these findings is that the sensitivity and specificity and positive predictive value of inter-alpha inhibitor proteins exceeds that of all the widely used biomarkers, including CRP and procalcitonin, which have been approved by FDA for diagnostic use, and we're striving for that classification with the FDA. I'm also showing the likelihood ratio. I think many people understand that the positive predictive value is for measurements that have very low frequency or very low incidence is not as reliable as the likelihood ratio. And again, using likelihood ratio, inter-alpha inhibitor proteins, far better diagnostic performance than these other markers. So I talked about the levels in humans in neonatal sepsis and adult sepsis. How about in necrotizing enterocolitis? This has a huge, represents a huge problem in neonatology. It occurs in 5 to 7% of very low birth weight infants in the Neonatal Research Network anyway. Has very significant mortality, 16 to 42%, and is associated with some significant long-term morbidities, ductus arteriosus, bronchopulmonary dysplasia, retinopathy, prolonged hospital stays, and a really important negative impact on neurodevelopmental impairment. The problem with NEC is, like sepsis, is the range of presentations and the range of findings. So NEC can often present insidiously with early nonspecific findings, including dysmotility, feeding intolerance, symptoms related to gastroesophageal reflux and apnea, but can also be associated with fulminant disease, rapid deterioration, shock, DIC, and death. Mickey Kaplan wrote a review recently on diagnostic adjuncts for necrotizing enterocolitis, and he's listed a number of them in using radiographic findings as the gold standard for stage 2 or stage 3 Bell's criteria, which means pneumatosis intestinalis or severe disease and surgical intervention. And a large number of analytes have been compared for their sensitivity and specificity for NEC. And as you can see, ultrasound, calprotectin, CBCs, C-reactive proteins, cytokines, and none of them have very good sensitivity and specificity for diagnosis of NEC, particularly in the early stages or the more milder forms like Bell's stage 1. So we've examined this extensively in prior studies. Hala Shaban was a fellow in my laboratory at Brown and Women Infants Hospital and collected this group of patients with Bell's stage 2 or greater necrotizing enterocolitis and compared those to infants who underwent evaluation for NEC, but who were later shown to have normal x-rays, negative cultures, and rapid resolution of symptoms, and they were able to return to feeding. We think this is actually a case-controlled good comparison. As you can see, there's a very significant reduction in inter-alpha inhibitor proteins in the face of necrotizing enterocolitis. Again, this is due to depletion and inhibition of synthesis. Burju Shah, another fellow in the lab, extended these studies and collected a completely new cohort of infants that were age-matched controls, necrotizing enterocolitis patients, and patients with spontaneous intestinal perforation. The vertical axis on this bar graph shows the IIP levels in control patients, significant reduction in NEC, and no alteration in infants with spontaneous intestinal perforation. As you can, this was compared to C-reactive protein obtained at the same time on the same samples in all those infants. You can see there's a much wider range of variation and significant differences weren't seen. When we looked at the ROC characteristics for inter-alpha inhibitor to diagnose radiographic or otherwise proven NEC, again, very high sensitivity and specificity with remarkable AUCs and very good performance characteristics. That's compared to C-reactive protein, which has a much lower area under the curve. Actually, I'm proud to say that this work was actually awarded the best clinical science abstract at PAS in 2016. How about experimental studies with inter-alpha inhibitor protein? So we've done a number of studies. I'll show first the adult sepsis, then some of the neonatal sepsis, and then some of the brain injury data. So this first slide shows the results of inter-alpha inhibitor administration in an adult model of sepsis known as cecal ligation and puncture. In this model, animals undergo surgery, the cecum is ligated, and depending on the size of needle that punctures the cecum and then returned to the abdomen, you get a fairly uniform polymicrobial sepsis presentation. In this slide shows the IEIP levels administered one after performance of the surgical procedure. The red bars show animals treated with inter-alpha inhibitor at 30 milligrams per kilogram body weight, and the dark blue bars show the control group that were treated, in this case, with human serum albumin. Again, this IEIP product was the GMP purified from residual human plasma, and we considered human serum albumin to be a reasonable control treatment. You can see the strikingly significant differences in mortality between the treated and the control animals, and that difference was preserved even when the IAIP treatment was delayed for up to 10 hours after cecal ligation and puncture. So we performed similar studies in my lab in neonatal sepsis. This slide shows the effect of the different IAIP dose on a LPS-induced model of neonatal sepsis. The vertical axis shows survival. The horizontal axis shows time in hours. And there's 3 different doses, 15, 30, and 45 milligrams per kilogram were administered an hour after the initiation of the sepsis in these animals. And the dotted lines show the controls that received human serum albumin at 15, 30, or 45 milligrams per kilogram. As you can see, there's a highly significant improvement in survival in this model of neonatal sepsis. This shows the effects of different doses. This slide shows the effect of timing of administration, whether the IIP was administered as in red, 1 hour, in blue, 3 hours after the onset of the sepsis model, or 6 hours after the onset of the sepsis model. And you can see that even up to 6 hours following the onset of the sepsis model, IAP is significantly better than the controls. These sepsis models are difficult. It's really hard to induce a uniform injury. It took a lot of fine-tuning of the dose of LPS and of the dose of live organism-induced sepsis. The literature on sepsis models has some controversies, pros and cons of the different models, whether it's LPS or live bacterial. So we carried out studies using both. We used both an E. coli K1 strain that was isolated from the NICU or a clinical GBS isolate. And this, for the sake of time, I'm just showing the E. coli K1 data, but you can see inter-alpha inhibitor at 30 milligrams per kilogram given after the onset of sepsis. After injection, the E. coli K1 is a highly protective prevention of mortality. So I know this audience is interested in neuroinflammation. I'm going to show you some results of studies performed by some of our collaborators. So this first work is done by Xiaodi Chen at Brown. He's a young investigator in Barbara Stonestreet's lab, and they've wanted to look at the role of IAP in some of their models of hypoxic ischemic injury. Preliminary to those studies, they examined the expression of IAP in various rat brain regions cortex, hippocampus, ependymma, choroid plexus, using the same immunological reagents that we used for our ELISA. Thankfully, they worked well in these different regions. And you can see the immunohistochemical localization of IIP in different cells in these different regions. And the cellular specificity was studied using double immunofluorescence, using double labeling with MAP2 for neurons, isolectin IB4 for microglia, and GFAP for astrocytes. And they concluded from this preliminary work that IIP can be detected in multiple regions and cell types of the brain, and suggests it may have an important role as an endogenous immunomodulator. So to study that, they used a well-characterized model of hypoxic ischemic brain injury in neonatal mouse pups. This is the Rice-Vanucci hypoxic ischemia model, where the animals undergo unilateral carotid artery ligation at postnatal day 7. They're then subjected to hypoxia of varying severity, varying durations, 8% hypoxia for either 90 to 120 minutes. In this series of experiments, they administered IIP 1 hour, 24 hours, and 48 hours following the carotid artery ligation, following the hypoxia exposure, and then at 72 hours, they carried out brain analyses. They used both moderate and severe hypoxic ischemic injury. Shown on this side are the sagittal sections of the brain of sham animals that underwent hypoxia ischemia but received placebo, and animals that underwent hypoxia ischemia but received interalpha inhibitor levels. And on the bottom is the quantification of brain infarct volumes in mixed genders, in male and in female animals. And as you can see, the administration of interalpha inhibitor following this regimen had a significant effect on reduction in brain infarct volume in both male and female animals. Others have reported some sexual dimorphism in this model, but we didn't see it with the interalpha inhibitor levels. Based on those findings, Louise McCullough, who's was chair at the time of NINDS stroke study section, which Barbara Stonestreet was on, was fascinated and wanted to study interalpha inhibitor in her model of adult middle cerebral artery occlusion. She was quite insistent that she wanted to carry out these studies in a way that she thought was more salient for adult stroke. So this shows the experimental timeline along the top. You can see the stroke model is initiated, and she insisted on delaying the first administration of interalpha inhibitor for 6 hours, then again at 18 hours, and then waiting to examine infarct analysis at 7 days. And she wanted to carry this out in both young and adult mice. The results are shown here. Again, using infarct volume on the vertical axis and different brain regions along the horizontal axis. In young mice, there's significant reduction in infarct volume in each of these brain regions in these 2 to 3 month old mice. And same effects were seen in aged mice, 18 to 24 months. Again, 3 different brain regions, significant reduction in infarct volume. So we were quite excited to see this, and we think this has important implications. So I've shown both adult and neonatal human clinical data, some experimental data. How are these interalpha inhibitor proteins working? So let me talk about the mechanisms of action that I outlined in the introductory slide. So this slide shows the effect of IAP on plasma cytokines in that mouse model of sepsis that I described earlier. We examined TNF-alpha and IL-10. The vertical axis shows the ELISA-based levels in the albumin-treated animals in red, and in the interalpha inhibitor-treated animals in blue. And these were trunk blood samples that were collected 3, 6, 12, or 72 hours in the survivors. And you can see there was a significant reduction in the pro-inflammatory TNF-alpha seen as early as 3 hours and got continued throughout the entire experimental period to almost normalizing in the survivors at 72 hours. The anti-inflammatory cytokine IL-10 was reciprocally elevated following the administration of interalpha inhibitor. Again, levels on the vertical axis, time after LPS injection on the horizontal axis, and you can see significant increases in IL-10 in this mouse model of neonatal sepsis. Hala Shaban, who I mentioned earlier, did some of our human studies, has since in her faculty career gone on to look at mechanisms of action of interalpha inhibitor proteins. And she's interested in extracellular histones and their role in inflammatory diseases, including neonates. Histones, neutrophil extracellular traps, and other forms are released in a variety of pathologic settings, including stroke, COPD, ischemia reperfusion, and other disorders, as you can see along the horizontal axis. These forms have these histones have a number of biological forms and vary depending on the source. I mentioned neutrophil extracellular traps. Those are released from neutrophils following acute systemic inflammation. Apoptotic bodies contain histone proteins from a nucleosomal breakdown, as does pyroptosis and necrosis. And these histones have a variety of systemic effects, including some role in bacterial killing and pathogen control, but in pathological effects on vascular tissue injury, particular endothelium, and ischemic injury in other organs. They lead to marked activation of the pro-inflammatory immune system by binding to a number of TLR receptors and release of cytokines of a wide form, effects on the inflammasome, and striking effects on the microvasculature and platelets. This is some of Hala's work showing the binding of different histone proteins to interalpha inhibitor, and to also show some data on hyaluronic acid. So this shows conclusively that interalpha inhibitor is a scavenger protein for these free circulating forms of histone proteins. That's corroborated on these in vivo studies where histones in combination with interalpha inhibitor or histone proteins in combination with hyaluronic acid were administered systemically, and then histologic findings and bleeding time were examined. The bleeding times are shown here. You can see that histones induce a marked prolongation of bleeding time, which is abrogated by interalpha inhibitor. Interestingly, it's also abrogated by hyaluronic acid, an important constituent of the extracellular matrix and in microvasculature. Histological effects on the lung microvasculature are shown here, and the marked congestion and plugging and distension of the intraalveolar septa is shown in the animals that receive histones alone. That is prevented by administration of interalpha inhibitor, as well as to a lesser extent by hyaluronic acid. Louise McCullough looked at some of these phenomena in adult human patients who had undergone ischemic stroke, and looked at the interalpha inhibitor levels, shown that they were reduced, and shown that that reduction is associated with an increase in the circulating levels of histone interalpha inhibitor complexes, suggesting that the endogenous interalpha inhibitor play a protective role in controlling these danger signals and these inflammatory markers. One of the important mechanisms of action of interalpha inhibitor is stabilization of neutrophils. This slide shows the effects of interalpha inhibitor at a variety of doses and or by Kunin in this model of neutrophil activation by sepsis. Shown here are the scanning EMs for the models treated with saline alone or human serum albumin, and on the bottom level, the stabilization of neutrophil membrane and neutrophil cellular size. And the bottom level shows the effect on form factor, a quantitation of that, showing that interalpha inhibitor levels have a marked stabilization effect on neutrophils and neutrophil breakdown and release of histones and extracellular traps. That is associated with a concomitant reduction in the production of reactive oxygen species. So this shows that different levels of interalpha inhibitor, this is an in vitro assay leading to activation of ROS by neutrophils, but nonetheless, you can see a very significant reduction in the expression of extracellular ROS following in vitro exposure of neutrophils to interalpha inhibitors. So I mentioned that we want to bring this work to UCSF, and I'm going to describe the preliminary data that was in support of our new SBIR award. We're applying for a phase 2B. You actually have to be invited by the Institute to move on to phase 2 awards. And we're pleased that the work I've showed you earlier led to this. So in our new award, we intend to validate the reagents, the detection, and the conditions for a rapid interalpha inhibitor assay. This is right now just a research tool with a, laboratory-based, highly sensitive ELISA assay, but can we come up with a more rapid assay, point of care, if you will, to bring this into the clinical arena? We want to compare the results between the rapid assay we've developed and the research-grade competitive ELISA. We collected a whole new round of residual samples. I'll show you those. And then we want to use this to begin to address the duration of antibiotic exposure and opportunities for reduction in broad-spectrum antibiotic use in different patient groups. So you'll recognize this lateral flow immunoassay device. This is a small cassette. This is identical to the antigen-based assays we've all been using for COVID-19. We have test lanes and sample wells, and using commercially produced models like this with immobilization of the antibody, the monoclonal antibody to interalpha inhibitor on this on these nitrocellulose membranes, and then inoculation with a really incredibly small quantity of serum. We can, and then using horseradish peroxidase to develop the, immunogold to develop the test lane, the markers, and then scanning with a scanner, you can see a very high correlation, R squared of 0.94, comparing IAP levels by lateral flow immunoassay with IAP levels by ELISA. And this work was just shown at PAS this year. So we've already conducted some preliminary data on this prospective observational study. This was carried out at Brown University and at Oklahoma University, where Hala is a faculty member. IRB approved collection of residual blood from infants who were undergoing evaluations for neonatal sepsis or necrotizing enterocolitis, collection of clinical characteristics of their data, and then samples were biobanked for measurement of IAP, but also other markers. And these were carried out at a variety of different postnatal ages. As I said, we wanted to examine infants who presented with signs of sepsis and or feeding intolerance. There were several groups of infants, 3. Those infants in whom discontinuation of antibiotics and or resumption of feedings was able to take place within 72 hours, and those would be our so-called case controls. Many of the reviewers of this work and publication have insisted on this kind of a control population instead of just age-matched controls. We compared those to infants with culture-proven sepsis and infants with proven necrotizing enterocolitis with modified Bell's criteria, stage 2 or greater. And then we also collected gestational age match healthy controls. I'll show you those results. Next slide. So sepsis, inter-alpha inhibitor levels at the acute event. Vertical axis shows the IIP levels. Horizontal axis shows the levels in patients with culture-proven sepsis, case controls, and gestational age match controls. You get highly significant difference, corrected for multiple comparisons. Some not insignificant variation, but these are standard deviations, not standard errors. And this shows the levels at in sepsis and NEC cases as well, and gestational age controls. So, let's see. We looked at the, I apologize, that one was mislabeled. That was, we also looked at sepsis, NEC, case controls, and gestational age match controls. Sorry, I mislabeled that one. So here's the sepsis, here's the NEC with both case controls and gestational age match controls. And here's the ROC curves for each of those. Again, for sepsis alone, for NEC, and for infants with both sepsis and NEC. About 25% of the cases of Bell's stage 2 or greater NEC had culture-proven sepsis. And you can see, again, the remarkable sensitivity, specificity, and AUCs for these levels. The data are really striking. So where are the opportunities for antibiotic stewardship? If you think about it, and we think about it a lot, children, infants undergoing evaluations for clinical symptoms, undergoing blood culture evaluations, or evaluations radiographically for necrotizing enterocolitis can fall into a number of groups. Those with blood culture positive, that's fairly clear. That's sepsis. Some of them may have high IIP levels, some may have low IIP levels. These infants clearly should be treated aggressively with antibiotics. These infants with culture-proven sepsis but high IIP levels probably deserve, we would say, continued antibiotic administration as well. But what about infants who undergo similar evaluation but have negative cultures? Those can break out into infants with low IIP levels or high IIP levels. The infants with high AIP levels, they may be those infants with quote unquote culture negative sepsis or clinical sepsis. Each ICU has its own culture on these kind of definitions. And this may be infants where there's an opportunity for shorter duration or discontinuation of antibiotics. The same can be true for infants undergoing evaluation for necrotizing enterocolitis. Those whose radiographic findings in clinical course are negative, that have high IIP levels, they may represent a group of infants in whom significant reduction in the duration of antibiotic exposure is warranted. So we looked at those findings in the infants that were enrolled in the preliminary data that I've just finished showing you. And this shows the different groups that we identified. So in infants with culture-confirmed sepsis, there were none that had high IIP levels, no infants with positive blood culture that had high IIP levels, 0. However, there were a few infants that were in culture-confirmed sepsis with low IIP levels. And all the infants with positive blood culture had low IIP levels. Similarly, in the infants with proven necrotizing enterocolitis, there were no infants that had positive signs and high IIP levels. All the infants with culture-proven radiographic or clinical-proven NEC had very low IIP levels. And you can see the duration of the antibiotics in these two groups was comparable and typical of what might be used for clinical findings. But what about infants with suspected sepsis, negative blood cultures with high AIP levels, or suspected NEC with negative X-rays and negative clinical signs, rapid return to feeding? We think these infants represent a group wherein the duration of antibiotic exposure and all the negative effects attendant with that, there may be significant opportunities for reduction in the duration of antibiotics once the rapid IAIP test results are available. So we have a number of other ongoing studies. I've described to you the work we want to do with suspected sepsis, NEC, and the rapid test. We want to seek FDA approval to put this forward in the CLIA-based laboratory clinical armamentarium. I didn't have time today to show you, but one of the nebulous diagnoses in perinatal medicine is infants born to mothers with a clinical diagnosis of chorioamnionitis. And in work we presented at PAS this year, we've shown that there's a significant alteration in some of those infants with chorioamnionitis, but not all of them. What that represents as an opportunity for clinical management, we're continuing to study. Pneumonia is one of the other can be nebulous diagnoses in neonates. So in collaboration with Nick Green at Brown University, who's looking at the reliability of tracheal aspirates and mini bronchoalveolar lavage, we're looking at the interop inhibitor levels in those infants, along with microbiome studies of the BAL work. I don't have time to show you that data. We haven't done many of the analyses yet. And we have an ongoing collaboration with adult ophthalmologic investigators at Sinai who heard this work and said, oh my, this would be incredibly valuable for retinal ischemia or endophthalmitis, which are extremely difficult to treat. And so we've provided them interalpha inhibitor level, and they're working on a retinal stroke model in a rabbit model. And we're seeking to further validate the rapid test and then go forward to FDA to pursue phase 1 and phase 2 safety and efficacy trials. We have an application outstanding with the Harrington Institute to actually expand the pharmacodynamic and pharmacokinetic studies in additional animal models. You can't do just rodents, as many of you know, so we're hopeful that that'll be positive. I can say that I have saved so many mice. I really want an opportunity to use this to treat neonates, particularly infants with severe NEC. I hate NEC, and it's a really intractable problem. So we're hopeful to bring that kind of work forward. And I've already acknowledged much of this work was done at Brown University. Yaopin Lim is my longtime collaborator and the chief scientific officer at Prothera. Nick Green is a neonatologist ID colleague at Women and Infants. And Ray Chen is the research assistant who carried out many of the collections that I described over the last several years. And at Oklahoma University, I already called out Hala Shaban and Burju Shah for their contributions. And with that, I'll stop and look forward to taking any questions or look at what's in the chat. I'm going to stop share so I can see the chat and see y'all. Okay. Questions?
I have one, Jim. This
Hi,
is Emmett.
Eamon.
How
Hi,
are
Eamon.
you? That was fantastic.
I'm delighted to see you.
Just quick question. Any sort of insight with respect to whether this could be used as a biomarker of neurodevelopmental outcomes in kids with like HIE, for example? Is there any animal model data that suggests it correlates with disease outcome sort of neurodevelopmentally as opposed to just stroke volume?
Yes, there is. And in fact, special assays had to be developed in order to measure those levels in the rodent models. And I didn't show, but Barbara Stonestreet's done some studies in a carotid artery occlusion model in chronically catheterized fetal sheep. And there are correlations in terms of outcome and severity. So I can try
That's
to.
very cool.
Yeah, yeah.
The assay, the lateral flow assay that you guys have is is it species agnostic at this point? Is it something that can pick up human as well as sheep and rodent?
It'll the cross reactivity in the ELISA using the monoclonal that's used in both the ELISA and the lateral flow assay is reasonable. Not great. That's why separate assays were generated, but it's not unreasonable. The better thing to do with experimental animals is just let us run the ELISA, because the ELISA performance has been validated in both species.
Yeah, I mean, I guess it would be, and obviously this is very selfish, but in our model, we have, pretty similar injuries, certainly metabolically, that result in, as is the clinical scenario, very different neurodevelopmental outcomes. And we have tons of serum samples banked from our animals that I think it might be fun to kind of look with this assay to see if the levels all are low in the setting of the acute injury, and then it tracks with neurodevelopmental outcomes. That might be really useful clinically.
So I think this work could have some valuable contributions to your model. So using acute cord occlusion and systemic ischemia, I think that will be associated with even greater levels of injury markers in circulation than Louise McCullough's carotid artery ligation. And I think that interalpha inhibitor administration in that setting could have significant protective effects. And I think those are both testable hypotheses that could be looked at with your samples. And the C in Padbury and Yaupin Lim stands for collaboration. So there's research grade material and also willingness to run those assay samples already confirmed.
And sorry, I don't want to hog the questions, but
okay.
One last follow-up. Any sort of either experimental data or speculation as to whether or not this might have an additive benefit with hypothermia? Like administering IAIP?
I don't know. Well, we've not tested that, but that's testable. I think my suspicion is that it would add an probably a significant effect, but I don't think it would be 100% amelioration. But because I'm basing that on Alistair Gunn has looked at a variety of other ways to potentiate the effects of hypothermia in his models, and he's been a long-standing collaborator with us at Brown. I've even visited him and gone sailing with him. So that's my hunch based on his work.
I guess its effects on TNF would probably suggest that it would have that direction based on some of Alistair's more recent stuff, right?
Yeah.
Yeah. Okay. Very cool. Thank you so much, Jim.
Thank you. Additional questions? Okay, well, I want to thank everybody. I hope I've finished. Yes, I have. A reasonable time. I hope I didn't talk too fast. And I look forward to telling you more about this work if we can get it launched here, and opportunities for collaboration here in other clinical or animal-based settings. So thanks so much.